I'm going to talk about perioperative risk assessment. So I'm going to focus on these areas. So I guess if you wanted to switch off right now and go and make coffee, then I think my overall message would be that no matter the risk prediction tool you use, the key thing, or you choose, or you think is best, the key thing really is all about implementation and how it's used, and not really so much about what it is. And I'm going to talk about, therefore, all the other bits and pieces, so face validity and accuracy, ease of use, all these other bits and pieces, as part of making the case for easy or easier implementation. So face validity and accuracy, posh words, what does it mean? Basically, does it make sense? Does it hold true? Does you know, we've seen data that says that hair color predicts risk of bleeding. That is apparently true. Redheads have a higher risk of bleeding due to some genetic factors, that the same genetic factors that make them redheaded also give them a slightly higher predisposition to bleeding. Doesn't necessarily make face sort of a face validity cut at first glance, but in the case of perioperative risk prediction, we want tools that we can intuitively believe in. We want them to be accurate, of course, and we want to know that they can be used for individualized risk prediction, and I'm going to cover that a little bit later on. So first of all, you know, what contributes to perioperative risk? And it's these three things, I think. The patient's health and fitness, their surgical urgency, and the surgical magnitude. So an unfit patient having a small operation will probably do okay. A fit patient having a big operation may have a higher risk. We all know that. That's intuitive. What's not on here is some of the stuff that's been thrown up, particularly in the light of the last 15 months and the way that COVID has affected all of our lives. And of course, what we now know better than we knew before, though we already knew it, is that that deprivation in particular, and potentially ethnicity, carry risks of adverse health outcomes that may or may not be modifiable in the short term. And certainly in the case of perioperative medicine, I don't think we've really done the work to know whether any of the risk that is associated with being poor or coming from particular ethnicities can be overcome through different ways of looking after them. And that, I think that's a thing for the future, potentially. This paper was published probably the worst possible time, in between two waves of a pandemic, for it to get any notice. But this is a paper that I think many people in the audience will have contributed to, so thank you for that. It's one of the papers that came out of the SNAPS-2 study, and it looked at the validity of various different risk models and compared them against you and me using our clinical judgment. And what it found is that the surgical outcome risk tool, which I'll hold my hand up to having a conflict of interest in that, I was involved in the development of it, performed well, but it didn't perform significantly better than clinical judgment, interestingly. If you look at some other tests, it did perform better than clinical judgment. But the take-home message really is that if you put the two together into a model that we developed as part of this paper, and combine clinical judgment with the objective measures of the surgical outcome risk tool, which I'll go through in a sec, you get a better prediction of risk, you get a better calibrated one, and you get the patients lined up in the order of risk better than if you used either alone. And importantly, the recalibration of the tools meant that you were mostly moving patients from a high risk category into a lower risk. And what that means is that we as clinicians are inherently pessimistic, and that's probably good. I think the older you get, the more pessimistic you become about a patient's predicted surgical outcome. And using this combined model actually reclassified some higher risk patients into a lower risk category. So this is an open access tool. There's a website that some of you will be familiar with. And my advice, and this isn't explicit in the paper, but the methodology that we used was that the perioperative team was asked what they thought the patient's risk of surgery was, and that was the clinician judgment. And of course, that's the best possible clinician judgment, because it's in the operating room or in the anaesthetic room, hopefully surgeons and anaesthetists having a chat about it together, but certainly experienced colleagues who are actually going to look after the patient, giving their clinical viewpoint. And that may not be a fair representation of all of the myriad of different clinical judgments that would come around from both the most experienced member of the team to the least experienced member of the team offering his or her opinion. So my view is that you should probably use the original sort if inexperienced colleagues or indeed patients are undertaking the assessment, but the clinical judgment sort model could be used if more experienced colleagues are undertaking the risk assessment. Now, as I said, I've got no financial interest, but certainly I think that obviously I have a small conflict of interest in that I was involved in developing the sort. And other models are available. And there are lots and lots of different risk models out there. This was one that was developed in New Zealand called NZ Risk, and it was based on the sort. It's got a very lovely website. And it's slightly different, and they've got a different calculation under the hood. But it's, again, a very simple measure that uses basic stuff about the patient's operation, their ASA grade, the urgency and their age and their cancer status to determine risk. And I think I heard the previous speaker talk about the NISQIP calculator, which I'm guessing, therefore, that you are familiar with. And again, lots of people really like this, possibly because it feels complex, and therefore it's probably good. And I think undoubtedly in America, this is the tool that you should use. Whether it's the tool that we should use in the United Kingdom, I'm not sure about, because I haven't seen much, if any, data validating it in our populations. And I think there will be differences. And I think, importantly, if you're looking at risk in a particular type of patient, such as a patient having an emergency laparotomy or a patient with a hip fracture contemplating surgery, then it's probably better to use well-established, well-validated, regularly updated tools like the NELA risk calculator for emergency laparotomies and the Nottingham hip fracture score for hip fractures. And so I think if you've got a surgery-specific tool that you have confidence has been regularly updated, then I would probably go for that. Now, that's great. So we can think about using particular models, but they've got to be kind of easy. And the other way that we can assess risk, and I heard this again spoken about earlier, is cardiopulmonary exercise testing, or indeed many other forms of assessing functional capacity, whether that's a Duke Activity Status Index, a 6-minute walk test, timed up and go as a very, very basic test, or indeed a 9-panel plot here from a CPET test. And you'll be familiar with this paper, I'm sure. It's been out for a few years, but it made a direct comparison between different ways of assessing functional capacity, including you and me giving our view on it against each other. And I think the key findings for me were that we're really bad at assessing functional capacity. And I wouldn't take that too much to heart. I think it's probably because we ask the wrong questions and patients don't necessarily give us the answers that we think they're giving us. So can you walk up 2 flights of stairs was the one we were all told at medical school to ask, but we didn't ask how many steps and we didn't ask how fast. And if it takes them all morning, then that's probably not a very good functional capacity, even if they say they can do it. And so something that's a bit more objective, but is still based on patients giving responses, like the Duke Activity Status Index, it is very likely to be better. And indeed, this study demonstrated that it was significantly better than clinician judgment. And I think that for hard-pressed perioperative services, having a screening tool which identifies patients who would benefit from further evaluation is a good thing. And the Duke Activity Status Index would seem like a reasonable screening tool to use that would then identify a group of patients who are unfit, who then could go on and have an objective evaluation. And the gold standard of those is cardiopulmonary exercise testing. So we've got some risk assessments. What do we then do? What's the point? So the purpose and impact is the bit that I think we need to perhaps focus on more now than the specifics of which tool that we use. So the messaging really around this is about how we communicate. We need to be able to communicate with our colleagues. So this is a multidisciplinary audience, which is really great. The surgeons and the anaesthetists and the nurses and the recovery staff, they all need to communicate in a common language. And therefore having objective measures of risk helps with that. I think that's one of the key differences between the MET study, which I just mentioned about exercise testing, and the SNAP2 study, is that we asked people to predict risk of adverse outcome as opposed to fitness, and those are two very different things to try and predict. And so I think clinician judgment is important, but backed up by an objective tool is useful. And then we need to communicate with the patient, and that's been touched upon this morning already, I know. And we need to use language that they can understand easily. And we can use language that means something to them. So higher or lower than average for this procedure, for example, probably will mean more to them than saying 1.5% or 2.7% risk of X outcome, particularly when you hear a 5% risk of death quoted to us, and we think that's high. But to a patient, that's a 95% risk of survival. And of course, we know that that's not really the case, and that behind that 5% mortality risk, there's a risk of a whole myriad of other problems. But communicating with the patient is not easy, and having simple tools and simple language like higher or lower than average, I think probably does help. And then we need to communicate an individualised risk to that patient, and we need to understand which outcomes matter most. And we'll come back to that again in a sec. And then the impact of that. So what are we going to do with this as far as our own clinical judgment and clinical planning is concerned? So we might select patients for optimization, whether that's prehabilitation if they're unfit or malnourished, or have psychological needs if we've done some screening on those. If they're obese, we might assess or treat them for type 2 diabetes. If they have obstructive sleep apnea, if they have what are called lifestyle challenges, I'm not sure I like the term very much, but if they smoke or if they drink too much alcohol or a lot of alcohol, we might refer them for therapies, although the evidence base behind some of this is a bit shaky. The key thing really is that the risk assessment is the starting point of a shared decision-making conversation. And I think with the very long waiting lists that now we're all faced with, in particular, that's going to become more and more important. It's also legally binding. It's in GMC recommendations, and so we need to pay attention to the shared decision-making agenda. And then, of course, as anaesthetists and intensivists and perioperative, we then might choose to modify the perioperative pathway or select them for particular interventions, such as hemodynamic monitoring, postoperative critical care, or whatever that might be, all based on that risk assessment. I'm sure you're familiar with the Montgomery ruling, but to cover it again, Nadine Montgomery, diabetic, short, and had a spontaneous vaginal delivery and a shoulder dystocia, which was well managed, but sadly the baby had a hypoxic brain injury. The baby's now an adult, I think. And well, of course, it's 20 years. So the risk of shoulder dystocia in her was 1 in 10. But in the overall population, of course, we all know is much, much lower than that. And the point that she didn't have her individualized risk of that complication shared with her, and she therefore wasn't able to share in any decision making about how she delivered the baby. And we all know that she took this to court. She won some money, but more importantly, she changed the law and the way that we think about consent. So shared decision making is an enormous topic. And a very, very important one. But you could be really reductionist and just bring it back down to these this 4-letter acronym. So encouraging the patient to have a conversation with you or whoever the member of the team is that is discussing with them the pros and cons of surgery, to think about the benefits, the risks, the alternatives, and what would happen if they did nothing, the BRAN conversation. And there is increasing evidence in different specialties. These are both examples from orthopedics. There was another one that came out quite recently, that conditions for which surgery was automatically assumed to be the right thing to do is perhaps that's the wrong assumption. And when you actually test it against less invasive approaches, surgery does not necessarily come out as being the best approach. Finally, I wanted to talk about normalisation. What do I mean by that? I want to normalise. I think we should all be looking really hard to try and normalise risk assessment. And by that, I mean, if you took a patient to cardiac surgery, before you get into the anaesthetic room or into the operating theatre, somebody's going to say, do we have an ICU bed? And that's just a normal part of the pathway. Nobody's going to forget to do that. It's absolutely ingrained in the way that you do things. For all of us giving anaesthetics, before we induce anaesthesia, somebody, thanks to the WHO checklist, is going to go, where's the consent form and have we all checked it? And before you put the cannula in or inject any of the drugs, you don't actually even need to ask where the capnograph is. But if it was missing, you would immediately notice it because it's an absolutely standard part of the way that we induce anaesthesia in the operating theatre. And so it would be really nice that before a patient was listed for surgery, the question was automated. What's the risk assessment? What's the, have we got the evidence of the shared decision-making process? Are we sure that this is the right thing to do? Is the patient sure? And absolutely normalise that as part of our perioperative pathway. Now, in order to do that, we've got to understand the limits of what risk prediction can do for us as clinicians and for patients as well. And part of that is understanding population averages and this concept of whether or not we can individualise a risk prediction down to the individual patient. So you're all familiar with the bell-shaped curve. That describes the average population for anything. And all that individualised risk prediction does, whether it's with a CPET or a SORT score or an Ottogam hip fracture score or anything else, is it reduces the size of the population for which you are predicting risk. So you're moving from the average patient having a Hartmann's procedure who might have a 2% risk of 30-day mortality, I don't know what it is, but let's pretend for a minute, to predicting to the size of the population of the average patient with an anaerobic threshold of 12 having a Hartmann's procedure, or the average patient with this list of comorbidities having a Hartmann's procedure. So you're just moving your bell-shaped curve to look from looking a bit like that to looking a bit like that on the right. You're just narrowing the limits of your distribution. The second thing is that all risk prediction has its limitations because there will always be residual uncertainty. And some of that will be down to the patient because all risk models and risk prediction tools are developed using historical data from historical populations. So, for example, a good example today is that all of the risk prediction tools, apart from really, really modern ones that have been developed for this purpose in particular, they don't consider the implications of COVID infection because COVID didn't exist 2 years ago. And so if we think that long COVID, for example, might be a risk to perioperative outcome, we simply don't know because we've not looked at that in a population of patients in which a risk prediction tool has been validated. And we therefore only use a limited list of variables, and we only include parameters which we can easily measure or we think are important. So the hair colour thing I mentioned earlier slightly flippantly, but we probably don't think that's important, but until we look at it, we'll never know. And therein lies a potential risk of risk prediction methodology. It's the reason why the NISQIP guys have had this surgeon adjustment of risks widget in their calculator for many, many years. And it's probably the reason why the SORT clinical judgment model works better than either of them on their own, because the clinician, an experienced clinician certainly, can capture a whole bunch of things that would never end up in a risk prediction model just because of the way that they're developed. So rare diseases, multi-system rheumatological diseases, for example, and indeed their treatments, socioeconomic status I've already mentioned, unusual surgical complexity, and indeed patient motivation and psychology. We are pretty sure that that does affect risk of different outcomes, but you don't commonly find them in risk models. Even if we're sure we can predict the outcome, of course, life does sometimes surprise us. I'm glad that this era is over, although the implications of it are going to last for a while, I think. And of course, there will be unpredictable or unusual events which affect patient outcome. So, anaphylaxis, somebody gives the wrong blood by accident, patient falls out of bed and bangs their head. And those things will, in population statistics, have an impact. The final bit is that residual uncertainty relates to non-patient factors as well. And that's because when we look at risk prediction and then what we do with the outcomes of those scores, we're chasing a moving target. Because if we think about what affects patient outcomes, it's patient factors, physical health, ASA grades, all these things, surgical factors, of course. But the other thing, and it's the reason that we get out of bed in the morning, is quality of care. And so if we get a patient on our list who had an anaerobic threshold of 10 and a peak VO2 of 12, and they're coming for an anterior resection, you think, oh, crikey, they're going to do really, really badly. And then you pull out all the stops, use all the fancy monitoring, you send them to ITU, you get the consultant surgeon and the consultant anaesthetist to do it, and you do everything that you can to improve their chances. And as a result of that, you potentially change their pathway and they do better than you would anticipated. And that's not a failure of risk prediction, that's a success of perioperative care. So we've got some clever stuff on the horizon. Everyone's talking about big data, electronic health records, machine learning, artificial intelligence. You know, these are all big steps forward, but in the end, the tool is important, but implementation is the main hurdle. And I think embedding individualised risk assessment into what we do every day, making it as routine as the capnograph for a perioperative anaesthetic, is absolutely critical, and that's the normalisation goal. So electronic records will help, undoubtedly, but I think it's human behaviours really that still need to change, and maybe we can focus on that in discussion now. Thank you for the invitation, Rob, and it's really nice to talk to you. Thanks.